Welcome, Dental Codology Insiders. Tonight we vote on our submissions and what we're going to do for the codes that we want to have heard at the Code Maintenance Committee next spring. Thing is, I saw this on Facebook yesterday. I thought, you know, this is pretty perfect for this group. You have three choices in life. You can watch things happen, you can make things happen, or you can wonder what the hell happened. And in this case, we are that second one. We are charting our future. That's why I know we have, especially in the last couple of weeks, I've really pushed many of you way out of your comfort zone of things you had no idea what you're doing, and you never saw the paperwork before. And I just really want to thank you, because what you're doing, I know, is so much, again, out of your comfort zone, but we're making a difference because we are charting our own future. And we worked really hard, the leadership really worked hard this year to try and come up with a way to come up with a different recipe for success. And I can't even tell you how proud I am of every single person that worked on all of these submissions, every part that you did, and our results. And I think it's important to understand is no matter what our results are tonight, we had still fantastic results because people have learned. So I'm not going to go through the whole, because I would like, if possible, to do this in 90 minutes tonight. You might have seen it was scheduled for 2 hours. I'd rather do it in 90 minutes. I want to recognize, though, of course, the people that were the chairs and the mentors, and they've got the arrows next to their names, and it's just that they have done so much organizing, getting people together, or trying to get people together, which isn't always the easiest. And I want to recognize them. And they're specifically Jamie and Linda from our non-therapeutic vaping group. We have the Patty Korecki and Patty Beeson from our provider language. We have Susan Cotton, and she has stuck with me, on the oral cancer group. We have Tasha and Kathy, as well as Melissa with Jill. So thank you, all of you. Now, let me explain, now that I put all these things together, which, by the way, I think I got the last one of the submissions at 11:30 last night, but we got them. We have, as a group, our work groups, our 5 work groups, came up with 4 brand new codes, 8 revised codes. Now, that 8 is a little bit confusing, even though if you did download from the link I sent earlier, the submissions, it looks like more than 8. The reason it's 8 is because we have two groups that have submissions for revising the codes for evaluations. So we'll be voting on those things separately. We have other ones, particularly in the oral cancer area, that it's going to be more of a suite of codes, and you'll learn more about how that part works if you haven't done it before. As I've already mentioned, I have a goal to get this done in 90 minutes. Because, well, I need help, though. I need help. Each of the work groups, I wish, those of you that have sat in these where you're working on codes like this, or submissions, or House of Delegates, or somebody that types in the changes as they're said, I always admire. I am not one of them. I can't possibly type in all the changes while I'm recognizing there's just no way. So what we need is probably 2 people from each work group that will be writing down, and again, writing down is up to you. You want to write in paper, you want to type it in, that's up to you. Any changes that we might end up doing from what different than what you submitted. We might have some tweaks, we might have some major changes, we don't know. The other thing is I need somebody that will watch in the chat box, to count votes. We are specifically going to be voting tonight. Other years, and those of you that have been at this for a few years know that we sent a poll out and that sort of thing. And we're doing things differently this year, and tonight is the night that we're voting. Now, one of the things for the way we learn this process is to behave as if. This is, by the way, if you're thinking, whoop, we're almost done, we're not even vaguely done, there is no done when it comes to this stuff. But we will be getting, after we submit our own submissions, the ADA will put all these things together, and then around the 1st or 2nd week of December, all the submissions that go to the Code Maintenance Committee will be published. In the idea that we want, one of our primary goals is to get a seat on that committee, we behave as if. What does that mean? We review all those and we vote as if we were on the committee. What you're looking at that, and if those of you that were working on those forms saw that in the last section, this is what is used by the committee eventually on what the votes are. The votes are yay, nay, or abstain. If they say they decline, they accept or decline, they will put explanation in there. We're going to kind of use that process here. We will be using that process when we have all the codes, all the submissions later on. But it's just going to give you kind of a dry run on that. So what we're going to have is in relationship to each of the submissions that we're going to review tonight, eventually I'm going to call for a vote, and you have a choice to say, yes, we're going to accept it as it is, or with the changes we've discussed. No, we're not going to accept it because you're just not in favor of it. Or maybe it's just not ready yet this year, and maybe we need to work on it for another year. I know for anybody that's been working on this stuff, if that kind of a vote can be painful, but it's not personal, okay? One of the things that this is about, yes, what's the best for patients and what's the best for practice, but it also is politics and strategy. And so if we vote to ultimately not accept something this year, we need to bring it back next year. Again, we're doing it as a team and as a group of people, especially those of us who've been at it longer, because it's what we see as what we think is going to work or not. Again, this is strategy. So, again, thank you for all the multiple meetings that people have held. They are all over the place. I've been downloading those puppies into the Insiders tab of the Insiders part of Dental Codology. Again, lots of meetings. Now, I want to be real clear on the way we're going to do this tonight. We are not going to be rewriting and starting from square one. And if you want another committee and you see something that this committee has done, you want to start over. Work groups the idea of work groups is to do committee work. This is time for voting. Not that we can't tweak it or whatever, but we're not going to start over from scratch. If it's something we feel like we need to start over from scratch, then that might be a reason that we push it off until next year. So what we're going to have is, as I go through this, the liaison for the group or somebody else that the liaison has asked to do it for them if they aren't here, or another spokesperson, will explain why the decisions were made that were made. Now, we can have some discussion, but I'm going to limit the discussion too, because we have a whole bunch of them to go over, okay? Now, one of the filters I want you to be thinking through and listening for is, ultimately, these are who we need to vote to support us. This is the 21 members of the CMC. And we can say, hey, this is the way it should be, and we believe this. And yeah, I get that. We have some really enthusiastic people here, but will they get it? Did we write it in such a way to convince the people here? Did we make any connections with any of those groups to maybe start that process? And I know we didn't have as much success with that as we have other things. But this is the filter through which we need to look at this. Now, the only way I could ever do something like this is on screen, is that I'm going to flip things over. But I had a couple of our liaisons that because I was asking, what order are we going to go in? And that's when I sent it to you, said, we're going to go in the number order that I numbered the submissions. And then I had Melissa Bracco from the East Coast and Jamie Collins from the West Coast, that Jamie was going to be late, and Melissa said that's really late for her, so I flipped them. So the group that was going to be last is going to be first, and the group that's going to be first is going to be last. So if you've got your submissions out in front of you, yeah, I did that at about 10 minutes to 7. Hey, changes happen. So we are going to start with the biofilm management and maintenance group. Okay, and Melissa, are you going to be the spokesperson for them, or are we going to have or is anybody else going to do it? Melissa?
Sorry, my computer was being glitchy. Yes, I'm going to be the spokesperson for the group.
Okay, great. Okay, so Melissa and Jill and the others on the group, I knew Eric was there. I mean, they come up with 2 submissions. Both of them are new codes. And what I did is I have up here biofilm management code first. So what we're going to do is, if everybody else can mute your mic for right now, and we're going to give Melissa the floor first to talk about the biofilm management code and what the discussion is of this. Now, what I have up here, just so you know, because you were going to be first, I would have explained this earlier, but you were going to be last, is all I have up here, Melissa, is I have the code. I just kind of took it off the form, okay?
Sure.
Like this. So when you want me to move to the next thing, just let me know, okay?
Okay. All right.
All right.
So as far as biofilm goes, initially we had started out on the course of we needed to get a code in place for what I like to call aqueous powder streaming, and what the rest of our dental community knows as air polishing. And as we kind of worked through that, we decided that we didn't want to really limit it to just one treatment modality or talk about one specific device that is used to disrupt biofilm. So we were trying to leave it very broad and open so that we could also use this code in instances like the use of the laser. We had a great discussion with Dr. Eric. I forget how to pronounce his last name, but he was amazing when he joined in on our meeting, and we talked about ozone therapy with him. So we were trying to kind of keep it on the broader sense of being able to encompass different kind of treatment modalities that all, at the end of the day, disrupt biofilm. And the reason why, because you might then say, well, why do we need a code for that? Aren't we doing that in, our prophy appointments or our peri-maintenance appointments? And yes, we are, but we're trying to come at this from a different perspective. So it's not in that normal, inside the box, let's see our patient every 3 months, 4 months, or 6 months. So this code could be utilized. Let's say, you see a patient and they're having a really hard time, they're periodontally active, and you know that there's a lot of reaccumulation. You want to see them back in 6 weeks, and just go through and use your airflow device, or use your laser or ozone therapy to help disrupt that biofilm and get them healthier. Or a situation where they had a systemic health issue that their oral disease state was impacting and making that worse. So, utilizing it in that way and approaching it in a really synergistic healthcare kind of approach. So I'll be honest with you, this code needs, I think, some more work before we actually are able to submit it. But the science that I want to really stress is how, we have all the sciences laid out in front of us now, how oral systemic is being impacted by specific oral pathogenic bacteria, all the new science that's coming out about the link with Alzheimer's. There's just so much that science is proving that we need this more than ever. I think P. gingivalis, I was just having a conversation the other day that it's in the synovial fluid of RA patients. So, utilizing this in a way where we're not, like I said, being in that traditional approach.
Anybody have comments?
So this is Kathy. So are you suggesting this should be ready for this year, or we should work a little more on it and do it next year?
Well, I think that it just needs, because we're submitting, when are we actually submitting? November?
No, we are submitting, this is it, tonight's the deal. Because what we've done and what we've learned in our process is we can't wait until November 1st, because if there's something that's not right with it, we don't have any time to correct it. So that was why tonight is the final. What we discussed is that we will have the discussion here tonight, and if we want to do some tweaking, that's fine, but you will see at the end, well, you won't be here then, that all the codes need to be into Kathy by the 5th of October, so she can do a final review so that we can get them submitted to ADA, because Kathy's developed a relationship. Well, Kathy, talk about the relationship you have with ADA and what they will do for us if we are not procrastinators. I'm not saying you are, Melissa, by any means. I'm just saying it's just the way the committee goes. So right. Go ahead.
Several years ago, I learned the hard way that if you don't get it in on time when you have things going on, you're told to wait till next year. And that happened to me. So I'm very aware that if we get it in by like the 10th of the month of October at the very latest, we are viewed more favorably by staff who may have to ask us for, can you send us some more information, or you filled out the form wrong, or whatever it is, because they end up getting so many sent on October 31st that it's crazy. So if we get one of the staff members, and I can give her a call whenever I need help, and she'll get it back to us very soon. When I submitted last year, there were a couple things on a couple of them, and I swear within 2 days of me submitting it, she got it back to me so we could make those changes. So that's why it's so important to give us a 2 to 3 week lead time before the November 1st deadline.
It's part of the politics we've learned. Melissa,
Exactly.
what do you think still needs to be added? Or what do you?
I just need to add a little bit more science to it. I mean, I have it all. I just didn't have the time to put it in. I have my clinical images that I unfortunately left my USB at my office. I didn't have the time to put those in. But I would like to hear the feedback of the group. And then I think by October 5th, I definitely can get that stuff done. But I'd love to hear what other people have to say. And then we can maybe make that call based on that.
I agree. Comments, I will call on you if you don't. Okay, Eric's here. Eric, your name got mentioned. Are you there, Eric?
I'm here.
There we are. So I know you're talking about ozone. What do you think where this committee and this group and this submission is at this point? There's no wrong answer.
Well, I kind of agree with Melissa that there needs to be just a little bit more wording to it to back it up. I don't think we need to put a huge amount of hardcore science into it, but I think it just needs a few more words to it. That's all.
So, okay, thank you. Jill, I know you've been working with Melissa on this. What do you think?
I agree. I think a few more words to it, and I think that would be great. Any suggestions for that? Yeah, that's my opinion too.
Okay. Well, I know you were.
Call out.
Pardon?
I was going to call out on Eileen and see what my friend the wordsmith and the oral systemic expert has to say.
Sure. Eileen?
I'm here. I think we're very, very close with this. I think now is the time. I think that choosing a few more words will get it out there. And if we can reference some of the science that's out there, at least it's out there, because science has never, ever given us such an opportunity to raise our profession. And by having it in in a different code and not associating it with a pro fee, we're really making a different mark. And the time is now. So if we can, give any help to this and put any more words to it, we're at a tipping point in the profession, and I see this at school, and more they're just trying to make us janitors. And we are medical healthcare providers, and this is what we do. We can help people manage their diseases, and what we do is so important, but the link hasn't been there. And
okay, I'm gonna call. Thank you, Eileen. I'm gonna call on Val. Val, you were on the biofilm when we did this. Tried to do the same thing 2 years ago. Can you talk to us about your experience and any perspectives that you might have on this? Have we written this time around in a different enough way that it could possibly fly?
So, Patty, thanks. And I have been on the road the last 2 weeks. I'm actually driving home right now from the airport. So I wanted to let Melissa know that I was going to reach out to her. I'm actually going to be in my home office all week. So I will take a deeper dive into this. I do, I agree with everyone saying, and, Eileen, I love what you said. I just got chills when you said the time is now. And so we have, I think that I like the way it's written, but I agree. We definitely need, like when we submitted this for the wound healing and whatnot, having those clinical case studies, having the science along with it, I think it's going to be impactful when we have it all packaged together. Because all I'm seeing now, I haven't read the whole thing, so perhaps that's what I'm missing.
Patty, this is Kathy. I have the
Patty,
Oh,
Okay, go ahead, Kathy. No,
I
whoever's
have
next will go.
I have the letter, the request, the form on why it was, why the disruption
Right.
of biofilm 2 years ago was rejected. It says how it was written, the title was disruption of subgingival biofilm using air and water pressure combined with low abrasive powder on two surfaces, saying that it is for a therapeutic procedure for biofilm disruption. The CMC determined that this action request is for a technique that is appropriately reported with CDT D6101. Which is the debridement of a peri-implant defect. I have to apologize, I have not read your entire change request form, but I think you should address this under the comment section. Say we recognize that back in 2017, when we submitted yada, 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 that you determined that it was appropriately under CDT 6101. We think that if you really read that definition, it does not apply. I think you have to address the fact so they know, yes, we talked about it 2 years ago, because there will be dentists like the endodontists who probably didn't pay attention 2 years ago. And, to remind them that, yes, it was discussed. However, if we really took a look at that definition of the 6101, it does not apply.
If I can interrupt, this is Eileen again. We have to make the definition that the disruption of biofilm is not just for implants and implantitis. This is for anybody that has these kind of, whatever they have in their mouth. And science 2 years ago, with all the studies with P. gingivalis, that just was really proven not that long ago. Also, with regard to air polishing, which they might confuse, we're adding different chemotherapeutic agents. Erythritol has a great science behind how it really works to disrupt things. So this is a whole new ballgame.
Oh, and I agree with you totally, but there will be men and women on that council that will go, well, this is the same as they gave us last year, and they'll cut it off. So if you at least somewhere in your documentation address, we realize something similar was discussed in 2017. And
I agree.
That's all.
No, I totally agree with that.
And if you,
I love what you've done.
This is Val again. And if you guys remember when we were there 2 years ago, they shut down Noel pretty quickly because they were under the impression that we were trying to get something back or pass via the vehicle of an air polisher, right? The airflow. And they made comments on the fact that it's an instrument or tool. So we really got to stick to the science and stick to what it's actually doing.
Absolutely. I think it's written very well. I like it.
Kathy, Kathy, this is Jill.
Yeah.
Could you send that wording over? This is Jill. That is very good what you just said. Could you send that wording over to Melissa and she can add that into it? Because I think that part is important to be getting in the beginning.
Absolutely.
If you could send that over to her, then she would have all that documentation. And yes, we recognize that this is, we're not labeling anything in particular because that's exactly what they do not want. But another question is, you said people have commented and said, I think a little more wording. Where do you think a little more wording is necessary?
The end.
In the descriptor?
Yes. At the end of the descriptor.
What would you put in there?
At the end of the descriptor.
Let's see.
I have to tell you, this is Kathy, from my perspective, less is more. And I kind of like the broadness of the descriptor myself. We don't want to get too much locked in because science does change. And I think what you've written is very well fits what describes what the nomenclature is. That's my own opinion.
Okay.
There's another aspect of it is nobody actually sees the descriptor.
Yeah,
let's play the game. Let's play this game all the way out here, and only people on the committee ever see the rationale, and only people on the committee, usually, and very few others, other than geeks like Kathy and I, ever see the descriptor. Why? Because professionals and people are functioning from just what they see in their computer system, and all they see is the name. So if we're going to think about adding something, or we want to add something for greater clarity, we might want to think about where we're going to put it. Not for just because we're right and we know we're right and we have the science, but for what we're trying to do to influence behavior. Huh?
Okay.
Okay.
I agree. That's why we kept it like it is. This is Jill. But I think that wording that Kathy has, if she sends it to Melissa, I think that's very important to add that. I agree with that.
This is Melissa.
Another part of having and recognizing that is what we are also have been working to do with this group is not just establish that we want these, different submissions and codes, is that we are a very interested party that is getting the continuity of the work that they do. We want to be a member of this committee. Again, it's behaving as a member, and a member would know that was discussed 2 years ago, and they would bring that back. So, and especially because it's our group that brought it forward. So that continuity of behavior has another value beyond just this one code.
Dr. Eric, do you think that this is broad enough that you could still apply this with your work with ozone? And Jill, do you feel the same way with laser?
Definitely.
Definitely.
Well, somebody's asking, this is Siobhan, somebody's asking about, in the chat, Lucy, she's asking, how is ozone applied? Should it be method of therapy instead of instrumentation? Because I was looking at the word instrumentation too, just as long as it covers those things, laser, ozone, and so forth.
Right. Laser is applied with the handpiece, and so is ozone. So they're both, the laser energy is topical, and the ozone gas is topical. But they're still being applied with a handpiece type instrument.
There you go.
And airflow is the same. Airflow is done with either a supragingival nozzle or a subgingival nozzle.
You can also apply ozone gas with an injection with a syringe and a needle, but that's still an instrument.
Okay, let's move forward then. And you know what, Melissa, if I have these messed up, because this is the one that's for the implant maintenance.
Right, right. Yeah, you had it's okay.
Okay. So explain the implant maintenance and how your committee came to the decision on this, because this year we had submitted 4 this year for 2019. Yeah, you've come to a very different decision. Can you explain that to the group on what your thinking is and how we've come to this point?
Sure. Well, we definitely learned from all of you amazing women that have been doing this hard work with the CMC that less is definitely more. Anybody who is working in implant dentistry knows that it is so multifactorial and there's not a one-size-fits-all approach. So last year, we really were trying to hit the gamut of all the different types of implant patients that you would encounter in practice. And I think we just gave them way too much information and completely overwhelmed them. So on one of our calls when we were discussing with the Profi group, just adding some wording that Siobhan worked really hard on getting ADHA to recognize at the annual session, adding words like prosthetics to that nomenclature. I was really hopeful that if that goes through with the Profi group, it kind of covers more of our patients in the implant arena too, with our patients that just have a single crown or an implant bridge. So we really just kind of focused on the implant patient that has the fixed supra structure that's not coming out while we're seeing them for their maintenance appointments, because we already do have that code D6080 that is for when the whole prosthetic is removed, everything's decontaminated, and then the prosthetic is put back on. So many of these patients that's not being done every time they're in their appointment for maintenance. And the ACP just released a paper recently stating that that's really doing it frequently, really not a great situation for the patients. So it was kind of like, as I was going through last year's submissions, I kind of hit myself in the head and was like, duh, we didn't really specify that it was, in all the work we did, we didn't specify that this was to not be removed. So I just made sure we really focused on that in this submission.
And how did you decide per arch?
Well, that was something that we talked about last year, and it's because a lot of these cases, like I have so many patients that might just have a full traditional maxillary denture, but have a fixed hybrid superstructure, implant-borne superstructure on the mandible. Not every patient has both maxillary and mandibular fixed cases.
Comments, questions, anybody?
I love this. I absolutely love this. Instead of putting per arch, I would suggest creating a third code so that this says maxillary arch and another one says mandibular arch. So
and I agree with Kathy, and the reason for that is the direction that the coding committee has been going in the last several years, is rather than putting a per arch, I'm not sure why, I have a feeling it's a metric thing, but you might want to have, yes, so then that's all that would need to be done, is one is maxillary and one's mandibular.
So I just photocopied the one so that, you don't have to change anything. Unless you want to put a picture of the maxillary in the maxillary and et cetera.
We have somebody else that wants to share an opinion, don't you, Anne Marie? Write it in the chat box. I don't have time to read it.
Yes, I just put, it's a great code, and I agree that individual codes, knowing how the 2020 codes are coming out now with per arch. Everything is per arch. So that would be, not per arch, per maxillary and mandibular, sorry. Maxillary and mandibular. So I think that would be a better addition to this rather than the per arch. But great code.
Yep.
And the other thing too, and that's the other part with when we're doing this, you watch trends, and you watch trends for, because I've watched it, and Kathy has too over the years, where at times when we've got the nomenclature is really, really long, and there's very little descriptor, and then other times when there's very little name, there's little to the name, and there's a lot in the descriptor. This tends to go in cycles with this committee, and again, that's a trend that we've watched over the last few years. So that's part of looking at the bigger picture and the politics. So any other comments, any other questions?
So I do have a comment. I'm sitting here. Yeah, Patty, it's Siobhan. I do have a comment because I'm sitting here and I'm just looking at the descriptor, and it says the removal of biofilm. Now, for consistency, we're submitting other codes with language destruction of biofilm. So for consistency purposes, do we want to keep it as removal of biofilm or just to use destruction?
You know what? That's actually my bad. We talked about that, and I forgot to make that change because it's supposed to say disruption of biofilm, removal of calculus. And so thank you for picking up on it, Siobhan.
Okay.
Okay.
Patty, this is Jill. So let me get this straight. So otherwise, this is okay, and but to have two submissions, one for maxillary and one for mandibular, correct?
Correct.
That's what we've discussed so far, yes. We have to vote on it now. We haven't voted on anything yet as an entire group. So who's going to be my vote counter in the chat box? Somebody watch the chat box, because again, I put all of this in there. I didn't know how far we were going to take, how much we needed this, and how many people had. So I'm going to just go right to the voting screens. So let's first vote for biofilm management. Again, we talked about a couple of tweaks. Do you say yes to that, no to that, or next year? Write your vote in the chat box.
Where's the...
Everybody voting that wants to vote? We've got 30 people. Love to see all your opinions.
Can you vote yes for me? I'm having a moment.
What? What'd you say, Eric?
Can you vote yes for me?
He wants you to vote yes for him. He's having a moment.
Yeah, thank you.
Hi, I don't mean to interrupt, but this is Liz. I vote yes, too. I don't know how to do it via chat on my phone.
Okay, got it. Thank you. Thank you. Okay, I think we have a majority already. Anybody keeping track? All right. Well, there we go. Connie Simmons. All right, Connie. Connie voted for 3 people. Good job, Connie. All right. Then let's do the implant maintenance. Yes, no, next year.
Liz and I both want to vote yes.
Connie, you going to vote for everybody again? By the way, it's really funny while we're voting here. Every year at ADA, they try to use an electronic system to vote. And even, well, 2 years ago, we actually saw and realized that they realized by the, I think once they passed like 11 of them and they realized their voting machine wasn't working right, they didn't go back and re-vote. And every year they end up holding up these yellow cards. They cannot get that technology ever to work. So our way here is working at least as well as theirs. Would you agree, Kathy?
Yes, absolutely. Actually, I think ours is better.
I think so too. Everybody vote that wants to vote. Okay. Moving forward, we've got Patty Korecki's group. Patty is, I know Christy is going to work with you. Christy Joe is going to also talk about what these codes are. Now, let me explain a little bit how I did this. When I was looking over the submissions, it appeared to me that your revision to the 019 code and the revision to the 0150 code, the rationale was very similar. So what I want you to do, and this is where we're going to have some overlap, and that's why Susan Cotton and the oral cancer group is going to go next, because we also have that, our group, the work group, also has revisions to the 0150 code. So this is where we're going to have to vote twice. So based on how things look, and Christy and Patty, you can let me know if you need me to put, because I have all of that stuff in there as you know, if you want me to flip to it, okay? Or what we can do is you could just explain, Patty, I think you're going to talk about the 0150, and Christy, you're going to talk about the 0190. So Christy, do you want to go first? And Connie, I know you're also on that committee, so whatever way your group wants to jump in here together, all right?
Sure, and I can talk a little bit about 0190. I work for an organization that does a tremendous amount of screenings and assessments, both in Head Starts and elementary schools. And one of the problems that we face is that dental hygienists can't charge out for assessments and screenings. And even as dental therapists, sometimes we can't charge out. We certainly can't charge out this one because it says a doctor only. So what we end up having to do is bill out under the doctor instead of under the actual provider who provided the service. And we're afraid that at some point in time, it's going to prevent us, even now it's a bit of a barrier, it's going to prevent us from seeing these kids who are the most in need, right? You're talking about Head Start kids who already meet all kinds of low poverty and low thresholds to be qualified for the programs at all. So just taking the word doctor out of these codes and putting in provider is going to help ensure that access to care stays there. It's one of the things that we really struggle with. In our particular practice, we just deploy our dental hygienists to go out and do assessments, take x-rays, make clinical notes, do radiographs, and then we sit down back at the office as dental therapists or dentists, and we review all that information. We come up with a treatment plan so that we can deploy providers into those areas. So not being able to use this assessment code for someone who isn't a doctor can be quite an obstacle for us. And like I said, it's for those who are most in need.
Terrific. Thank you. If I can ask, your group selected 2 codes of many that have provider-specific language. How is it that you decided on these 2 codes versus the myriad of codes that have some provider-specific language.
I just sent out an email asking for votes, and that was the two that the group decided were important enough to address at this time.
So this was a starting place for this? That's what the discussion was? What was the discussion on the committee, on the meetings?
Really, it was just over email. So there really wasn't much of a discussion, but we had been discussing all the codes that we had been looking at for a number of months. And I think that with the change in science and the change in our field, that it's important that the people that are now being given legally the ability to make screenings and exams, the real life application of being able to allow exams and assessments as part of their scope of practice.
Okay. Connie, do you have anything to add?
No, not really. I mean, that was pretty much what we had discussed at most of our meetings. I mean, I did, I had talked to Kyle Isaacs, asking her if she was having problems with it. Her main issue is she doesn't really do much with insurance patients, so she can kind of charge her clients what she wants to and not be as worried about particular companies maybe not covering a code because she's not credentialed with them, I guess is one of the things we were talking about, is that the insurance companies a lot of times, you know, aren't accepting dental therapists, aren't accepting all of these other areas that we're moving into, and that's generally, they don't care what the code says. They just said, we're not credentialing you, so you're not going to get coverage by us. And so I think that was the biggest part of our thinking. But I think if we can do starting out with these exam codes and then build on it in future years, but we have to have a place to start. And as you know, when you take too much to them, they get overwhelmed and just shut down as well. So I think concise and to the point, and let's see what they do with these as a starting point.
Okay, two things I'm going to jump on. You always tee it up for me, Connie, and then Kathy, I'm teeing it up for you. One of the things that we need to remember as a group, codes are not only for third-party reimbursement. HIPAA designates CDT as the standard code set for electronic health records. Therefore, even if nothing ever leaves your practice, you are required to use appropriate, accurate CDT codes. So with that being said, I love, and by the way, I've talked to Kyle about it too. It's like, we got to get out of the thinking that this is just about third-party reimbursement. These are really, the codes are about important metrics. And yes, not being credentialed and not serving the neediest, and we get stopped because of something like this. Yeah, that's definitely problematic. But we need to look at that bigger picture. Codes are not just for third-party reimbursement. Kathy, what I'm teeing it up to you though is we brought these forward before. Did you access that information? Because again, we have a specific reply because we tried to get this through last year.
I have it.
Kathy, do you have that up in front of you?
I do. Looking at what you're looking at, we had deleted the whole used by a general dentist, et cetera, and then just started it with this evaluation. So it's identical to what you have now, which concerns me only from the standpoint it could be denied just because it's not different. Because you have to have some different reason to submit a like amendment. The remarks for declining just says the requested revision was not accepted by the Code Maintenance Committee as a dental diagnosis and treatment plan can only be provided by a dentist by virtue of his education and training, period. So I can see them looking at this and going, well, there's nothing different than this that was presented 2 years ago. You know, why is this so significant at this point in time? If I can do a little side note to that, I really like the idea of presenting the DO 190 as that first baby step to taking a dentist out of the descriptor. And it might be so benign, and if we didn't do the 0150, this might be so benign that they'll vote yes, and then we can come back at another time on something of the 0150. But I like your rationale about doing this 0190 as kind of a first step. So I think we'd be I don't think 0150, what you're submitting is they'll be considering it anything different than what was presented 2 years ago.
And that is one of the, I think it's the 0150, the 0120, and the Profi codes are the codes that are used more than any other codes. So when you start messing with those, you got to be real careful with what you're messing with.
Yeah.
And because they will dig their heels in. We've had this experience before. But what I'd like to do for the rest of it, Linda, are you there, Linda Jorgensen? I see you there. I know you're at the Wisconsin meeting at the same time. Linda?
Patty, this is Jamie. I don't think Linda was going to be on tonight after all. She texted
I see her name there. I see her name there.
She said in the chat box she was there and she was listening, but didn't know how much she could contribute.
Okay, because one of the things that Linda's done a really good job in helping everybody to get is the idea that our whole goal with this is to create a provider-neutral code set. To have codes that have the provider, any kind of provider identified, doesn't make sense. It just doesn't. But that's why the idea of a baby step. Do we have opinions from other people? Thoughts on?
I have a question, Patty. So one thing, I'm sorry, it's Siobhan.
Hi, Siobhan.
One thing that you always say is very important is to be in person to give a justification. So I'm wondering if anybody will be available from this group to testify next year. And secondly, when we had our last group meeting, there was a doctor on the call who was speaking on behalf of the coding committee, and the dentist's attitude towards crossing out the word dentist and putting provider, how they are under a mindset, we got into this huge discussion about patient-centered care, but they are at a mindset that they think that we don't need them anymore. And the person who spoke first, I think it was Christy Joe, I'm sorry if I'm wrong, but she gave a really good justification as to why this screening code is so significant. So if there's anybody who can come and testify to that, because, if I'm just thinking the way they are thinking, they're going to see that word dentist crossed out.
Patty, if you go to the support, there are two letters, one from Christy Joe and one from Tommy Kell that answer those questions.
And this is where I'm going to be very honest with you. This is where I think this needs editing. This is lots of stuff, okay? And we get it, we understand it, but comes down to how much they will read. So I think this is where, again, if we're going to move this forward, we need to decide if we're going to do one, we're going to do two, and how we're going to cut this. This is because we might put this in here and think this is a beautiful thing. That's a button pusher. Putting a chart from ADHA in there is going to push their button. I'm not saying it's right or wrong. Kathy, do you agree? I mean, from your experience?
Yes.
Yeah.
I think we can put it in there, but I don't think they're ready.
I don't either.
Just having been to it, they saw this particular chart last year, and it just really, yeah.
This is Eileen. I was just wondering if you did not strike out the word dentist, but you added or licensed dental professional. So you're just adding, instead of striking out the dentist, then you could say dentist or licensed dental professional according to state practice acts.
Ooh,
that's a smart one. Ooh, I like that one, Eileen.
I like that.
This is Liz. I agree 100%. Dentist and dental professional.
Yeah, I don't think you have to have license because it'd be according to the State Dental Practice Act, but yeah, I like it.
Like it, because Natalie, you can jump in on that one. Yeah. Okay.
Who needs those dentists anyway?
Yeah, we wonder about that. We need you, Eric. We are all the people that learned about ozone just from your call. It was wonderful.
It's your approach to patient-centered care.
Okay, further discussion.
If not, why don't we vote?
Okay, it's time. Let's move it forward. Here we go. 0190, we're going to do yes, no, next year.
Yeah.
Connie, you going to vote for everybody again?
Thanks.
And don't, if you really are no or next, you don't feel that just because we see your name, remember this is business, it's not personal. We know how hard the committee and the group work. We've got to look at the big picture. So, all right, let's vote then on the, oh, what happened to 0150? There it is, 0150. Good.
Someone better mute.
Okay, here we go. All right, Susan?
Yes.
Susan, Denise, and company. Here we go, oral cancer group. First of all, we got to brag on something. We're the one group that does have a co-signer on ours. Susan, take it away.
All right. So we decided, and well, we were led by our mentors so well to go with less is more. And so, Patty, do you want to move down to the next? Yeah, we did, just to mention, we do have Brian Hill and the Oral Cancer Foundation on here with us, which is huge. So we decided to go with, in the end, with nomenclature and no descriptor because of all the things that have been said previously. So an enhanced oral cancer examination to include a comprehensive risk assessment, visual and tactile, extraoral and oropharyngeal screening to identify abnormalities. And yeah, just our big thing, less is more. We wanted everybody to see that and not get into the descriptor. We did go down when we talk about, where is it? It is, I think, the third page, Patty.
I've got it up here. Look on the screen.
Yeah, okay. So we started with evidence from the ADA to begin with. There's a great video of a patient talking about how her new dentist did an extensive oral exam and external exam and found a swollen lymph node. She was subsequently diagnosed with oropharyngeal cancer. And that is right from their website. And also how they talk about they themselves, ADA, early diagnosis associated with best outcomes. And then we moved down into trying to keep this, you know, in that funnel, how the codes 120 and 150 both state an evaluation for oral cancer where indicated, allowing this to be optional. And as does the DO-180 states, this evaluation may include. So again, back to their wording, we then went to their 2017 oral cancer guidelines that say their expert panel says clinicians should obtain an updated medical, social, and dental history and perform an intraoral and extraoral conventional visual and tactile examination. So in their words, this is not an option. Where is the codes where this is stated now makes it optional? And then we then moved into what screening is, looking for cancer before a person has any symptoms. Early diagnosis. Okay, next page, Patty. And then talking about why healthcare providers and insurance companies, why this is important to them because of the cost. This is one area that I think we could get a little bit more information, is right here as far as cost. I'd like to see one more thing there. And then we gave more statistics on the cancer. Okay, next page, Patty. Again, just some more statistics. And this middle paragraph, Dr. Nemechek, he is a ENT, head and neck oral cancer surgeon here in Colorado. He wrote this middle paragraph, and we tweaked it some. And then our last paragraph, just to end up with a little bit
Can I stop you there, Susan?
Yeah.
Has he checked with his group to see if his group will sign off on this submission?
They're still talking.
Okay.
And
okay,
yeah.
so it's another coalition, and that coalition would be what?
American Head and Neck Society.
Yeah.
And they are actually the group that, with ADA, came up with their 2017 guidelines, and Dr. Nemechek was a part of that. So that would be huge to have them signing on with us, because they were a part of deciding on the 2017 guidelines.
You talk about HPV at all?
Yeah, right here we've got information about HPV. Well, we have throughout, just how we know it's the reason for this cancer being on the rise. And then we got a little bit more specific in the technical description and the clinical scenario. So technical description, this procedure involves a detailed risk assessment. And we really wanted risk assessment in there because the screening is not just what we see and feel. There's a lot of things that we know that we need to be asking the patients about. So to include a verbal inquiry, let me minimize that, and/or an updated new written health history with a visual inspection using operatory lighting, loops, and palpation for the necessary techniques used in oral and oropharyngeal cancer evaluations. And one thing that Brian Hill really wanted emphasized, and we don't have it in there quite as much as he would like, but is the risk assessment, and that screening for oropharyngeal cancer is really not what we see. It's more about those pertinent questions, that verbal inquiry that we're asking about. We don't want to wait until we see something all the time. Then the clinical scenario, we really wanted to emphasize that it should be used for all individuals. So an enhanced oral and oropharyngeal cancer screening would be utilized for all individuals, recommended as a routine screening for every age, and an appropriate medical referral made as indicated upon results.
I can comment here. One of the problems with this is we tried to figure out how to get that language into the name of the code or somewhere earlier, because this won't be seen by anyone, and we couldn't quite figure that out. I will want to add, though, with the enhanced oral cancer, this is their language. Kathy, talk about how you found that in the CDC companion. Kathy?
Yeah, I'm here. You know, I knew you were going to ask me. I can't remember how I found it. But there are, in fact, I was just picking up my CDT book because can you go back to what the actual descriptor is being proposed?
Sure. Maybe.
Maybe.
No.
I think you can broaden the nomenclature. There are codes that are pretty long already. In fact, I'm trying to think.
Well, she does that. I actually have the page of where you found it, Kathy.
Oh.
It's actually the CDT companion for this year, and the section is called Oral Cancer and Enhanced Examination. And one part of the paragraph, it says, how could a dentist report the use of additional diagnostic tools for oral cancer examination? And what it says is there is not an independent code for enhanced oral cancer examination, but there is a code that can be used when somebody's using, others. So in other words, there is a code for an adjunct. So that's where we pulled it from. It's like there is not a code for enhanced oral cancer examination. I think we need to talk about what other language we want to have removed before we start tweaking this thing, because there's a bigger part to this that could be really challenging. And let me move that forward. We are actually submitting to remove the language of oral cancer screening in these other codes. And whether it's the comprehensive, whether it's the periodic, or even in the 0180, okay? And there's a specific reason. Susan, why don't you explain that? And you guys need to talk, and I'm sorry, I have to run to the bathroom. I hate to say that, but talk among yourselves.
Well, the reason that we want to remove it from these other codes is because, well, where indicated, an evaluation for oral cancer, where indicated. Well, where is it not indicated? It is always indicated. And that is our reason for wanting to remove it from the 150, the 120, and the 180, is to get that language out of there specifically. So it is always indicated. And that's the reason for our new code. Remove those so it's not an option. Everybody's thoughts?
I think it's great. Because it should be considered based on what's going on in the cancer world. It needs to be its own procedure from a metric standpoint, and from the patients. We bill them a comprehensive oral and we tell them that they're doing cancer screening, but they may not remember that it was a separate cancer screening. They're going to bundle it, and then they won't. It can be confusing. I think patients, it would give them some sense of security, knowing, oh, I had a cancer evaluation and they didn't find anything. I think it's a very good thing for that.
Yeah, exactly. And that was one thing that both Dr. Nemechek and Brian said was, there is extra time in this procedure. It is a specific procedure that's done that's separate from everything else that's, included in here.
I had a suggestion back where you have descriptors, none. And based on the fact that the nomenclature, no one reads past that. But I was looking back under your rationale where you said the expert panel suggests. You could take that next session and say included within this procedure would be obtaining an updated medical, social, and dental history, and performing intraoral and extraoral conventional visual and tactile exam. And you might be able to, I think you need put a little more meat in a descriptor that isn't totally, repeating itself. I think it would.
Kathy, what we looked at with that is when we look at that section where this would go, where we think it would go, that section either has the comprehensive and all the evaluation codes are very, very extensive because of when they were done, and it has something to do with this, where I think this would probably, I don't know this, but where it would end up going is in the other section of codes that have almost no descriptors. That's
Okay.
part of what we weighed.
Yeah, I'm just knowing that some of these committee members, I don't read past the first page. So I was,
Well, I get it. I get that.
Yeah.
Absolutely.
Just a thought. But Susan, well, your committee,
So
well
Kathy,
done. Yeah.
Kathy, are you recommending that we change the nomenclature or leave that and just add some descriptor?
Right.
I have a question.
Because it doesn't have to be in long and involved, but you know, I like this idea of the updated medical, social, and dental history. That's not, yeah, that's necessary. As you mentioned, it's that kind of information that's going to lead us to other things. And yet, you know, I don't think it needs to go in the nomenclature, but definitely enhances the description.
Okay, I like that, actually.
This is Tasha. Maybe too, and I love what you guys have done here, but maybe to even just leave in the nomenclature to say an enhanced oral cancer examination, and then kind of what Kathy just said about the social and all of those health history updates can be in the descriptor, starting with includes a comprehensive risk assessment, update of medical and social history, and then, you know, visual, tactile. So that could be another way to do it too.
Well, we
You know,
discussed
we were at that point at one time where we had just where it said an enhanced oral pharyngeal cancer examination, and then we went back to having more in the nomenclature.
And part of the reason we did that is because when we went back, because we even were looking at doing risk assessment codes, like there's Carrie's risk assessment codes. We looked at this 45 different ways it changed. Oh God, so many times.
Yeah.
And what happened is we decided that when we challenged Susan, because Susan's the one that brought this one forward. I said, Susan, what are we looking for? And your answers was we're looking to change behavior. Now, change of behavior with a code is a stretch in a lot of ways, yet that's why we put it there, because again, remember, people only look in their computer and all they see is enhanced oral cancer examination. They're going to not do anything differently than they did before. That's why we decided to put it in the nomenclature.
Yeah.
Okay.
We could see that.
But I agree with having some of that language very well written in the other parts, so when the descriptor makes sense. Siobhan, you have your microphone on. Siobhan, you have something?
Yeah, the word enhanced oral cancer examination, it bothers me a little bit because I've never separated that from a head and neck screening. It's always head, neck, and oral cancer screening. And I think that, Susan, that's the behavior that you're looking for, is you want to advocate for head and neck examinations. So I'm wondering if it could read a head, neck, and oral cancer examination to include, and then you go into comprehensive risk assessment, visual and tactile, and you complete the describing of what it actually is that we're doing. But that's always bothered me a little bit because, and I know it's called the Oral Cancer Foundation, but I know that it's about
it's not from the Oral Cancer Foundation. Where that language came from is from the CDT. This is politics, okay? In the CDT companion, that's what I was reading before. It specifically uses that term. In the book itself, identifies a whole. It says there is not an independent code for enhanced oral. Okay, that's why we use that language.
So what I meant was, she said that the Oral Cancer Foundation is signing on to this. So what I'm asking is, they also advocate head and neck, not just the oral cancer.
Right. Can I address that, Siobhan? Because that's a good point, and we did have that in there at one point. We started with that head and neck oropharyngeal cancer screening. And one thing that was brought up by Brian Hill, who has been really trying to do this for many, many years, he said that the people sitting on this board really balk and get kind of, when you bring up adding head and neck to this, because some of them look at it as, oh, well, then we're doing all of these different things included in the head and neck that they say are not in our scope.
Mm-hmm.
So that was one of the reasons that we went with this terminology. I mean, that head and neck was something that we actually wanted to have in there to begin with, but that's why.
Baby steps.
Can I interject for a sec?
Yes.
That's why extra oral is there. Is that not included?
Yes.
So that is what the head, so we're basically saying that with the extra oral.
Yes.
It's just we're not saying those words verbatim.
Right.
Yeah, exactly.
It's a baby step.
Exactly.
Because where we're going to get, this is where this is such a big change, is that this is a separate procedure now. It is not part. When the adjunctive devices came out starting in the early part of this century, that's when this came up before. And at that point, that's when the wordiness of all of the evaluation codes got even more wordy, because and I wish I had the committee notes from back then. I don't, but and I wasn't attending then. And that what they did is they felt that they didn't want to have a separate code. Again, I don't know why. I'm sure we'll hear on this one. But all they did was they added to the comprehensive and all the other evaluation codes. The real kicker is that they did it adding the words where indicated.
Indicated, yep.
Yep. And again, the language there is as if it's optional. And that's where we even talked about at one point that maybe what we should do is just ask for that to be taken out. That's a really, really tiny baby step.
But I think with the social media and all the cancer that is oral cancer that's being, reported on, and I mean, it's a whole different world than it was back when they made it optional. I mean, thank goodness for people like Michael Douglas, who made it cancer is very well known, and people are coming out and talking about it. So, and particularly, Susan, quoting what their own website and their own videos. I love throwing the ADA language right back at them and say, now try and say it isn't needed. So I think we're in a good position to be able to support this.
Patty, this is Connie. Going back to what you said, I was getting ready to say the exact same thing right when you said it in terms of baby steps. Did you guys really discuss just taking out that part where indicated? I mean, I know it's important, we know it's important, but is that a baby step that we want to take, or do we want to just go for the gusto?
Yeah, good point, Connie. We did talk about that. In fact, when we first started this, we were going for a new code. And then we did backtrack and do that where we thought, oh, we'll just ask for removal. But then in our gut, all of us, I agreed, this is what we want to do, is go for a new code. Because of where this cancer is, it needs its code.
And Susan, from a political point of view, when you're giving testimony, if you find when that they're balking at wanting to create a new code, you as the submitter of this new one can say, well, how about if we have plan B? We can take out, you can amend, to what was being discussed about, as optional. Say, why don't we, if you're not feeling comfortable creating an own code, take out the word where indicated, so that it becomes a must do, not a maybe do. So you can make those on the floor suggestions. So kind of have that plan B in your back pocket. But I would agree with you. Let's go for the gusto and in the name of our patients.
Right.
That's what we're doing it for. It has nothing to do with anything but you know, providing this service, making sure as much as possible it gets done on every single patient we see.
Yeah. And Dr. Nemec wrote a really good little paragraph for us that we felt like addressed that and the incentive. I mean, really, that's where dentistry lives. It's about production. It is a business. It is a business, and it's about production. And if they are incentivized in any way to do this, you know, having a code doesn't mean they'll get reimbursed or whatever. But if it's incentive.
And the incentive comes with the metrics, because the more the doctors will see, well, if just like the other codes, that the more you use them, the more they get noticed and they get put on the, you know, forefront of things. So doing, you know, having something that says about incentive, it could be a possibility for future incentive, not just right now kind of thing.
Exactly.
Okay, let's move forward because, again, we want to try and honor the time. Now, let me talk about this a little bit differently. If we vote no to the code, the cancer code, the add additional code, we don't have to really vote on the other ones. Although, based on what we just discussed, maybe we do. Because you could say no to the others and say yes to just getting rid of as indicated. So I don't have all of those things there, but let's first vote on, do we say yes, no, or next year to the new code, the enhanced oral cancer code, with some additions that we were just discussing, including adding more to the descriptor. Sorry, everybody vote that gets to? Does anyone want to have a separate vote on that negotiation that we can possibly do? Or are we all just good with having the discussion of it?
I think we have to trust the people that are going to be testifying to make those decisions.
Any other comments? Okay, let's move on then. Okay, Tasha, Kathy, this is the more proceed code. So again, the way this has gone, I did fix this one there. See, Tasha, I fixed it. Oh no, I didn't. It still says aisled on 110. Oh well, that's all right. Everybody, we know that this is a 1120. So we'll fix it. So you want to talk about first do you want to talk about the three of them, or do you want to talk about just the Profi codes first?
We can speak to just the Profi codes first.
Okay, that's well.
Okay, so basically what we did, we kind of came back as a subgroup and discussed what we had talked about on our last DCC call, which was adding the prosthetic piece to our descriptor. So we did decide to do that, but we also wanted to add the disruption of biofilm. So I know there was a vote earlier on that code, so I kind of was wondering how this would all mesh with all of our codes. So basically, last time we presented these at the CMC, they said it was far too disruptive to, you know, remove the dentitions or make it specific regarding the dentitions. So we left that alone, and we came up with what you see here on the screen. We did want to also add oral in front of prophylaxis, because currently today just says prophylaxis adult, and that was just to clear up, you know, basically there's so many differences for prophylaxis. Just clear up that we're talking about an oral prophylaxis so people don't get that confused with antibiotic coverage and things like that. So we basically left the dentition as is, added the disruption of biofilm, and then our committee thought there was maybe some confusion about the control of local factors. So we just said, is it intended to preserve health, since it is listed in the prevention section.
Questions, anybody? We basically have the same thing for the child, right?
Yes, just we'll fix the typo there to 1112, 1120, and we did the same thing for the child.
One of the things we did, I don't know if you have it in a slide, Patty, was to define prosthetics, meaning it was, Tasha, you probably have the list in front of you. The prosthetics could be a fixed retainer, it could be ortho brackets, it could be, you know, yeah, there it is, fixed bridges, dental implants, space maintainers, or so they're not thinking, oh, an implant or oh, this. I mean, there's lots of different kinds of prosthetics, so we wanted to make sure that was in there.
And you have, for the children Perfi, you have these. I put these guys in here too.
And then for the 1110, which I think is the next slide, we did use a dental implant in this scenario, mainly because we quoted the 2017 workshop, and there's not really a procedure code for the maintenance, basically, or the cleaning around a dental implant that has peri-implant health. So now that we have those new clinical classifications, we wanted to use a scenario like this: a patient coming in for a prophy with clinical gingival health, has an implant. The prophy code does not talk about prosthetics, so there's technically not a procedure code for the person cleaning around that implant that exhibits peri-implant health. So that's why we use this specific scenario.
Implant maintenance, Melissa and your group comments. Any comments or thoughts on this? Siobhan, Val, Jill?
I think this is good. That's what a prophylaxis is. And I think Melissa signed off, but I think this is a great example.
And one of the things we wanted to do in the descriptor is really point out that it's meant to preserve health, because in the next code we're going to go to, we talk about kind of changing the 4346 to be more just about a patient with gingival inflammation, not so much generalized, moderate to severe, but because the 4346 is in the therapeutic section, and today we have a lot of patients with gingivitis in a preventative section. Our goal was to really separate clinical gingival health from patients with inflammation. So we changed the 4346 to reflect scaling in the presence of gingival inflammation. It is intended to be full mouth, performed in the same day after oral evaluation. And so you'll see also the disruption of biofilm in the descriptor there, and also the prosthetics added there. And then we thought that last statement should not be reported in conjunction with kind of limiting, so we did go ahead and scratch that. And we kind of explained in our rationale that, you know, as to why.
For somebody that's trying to teach what generalized moderate severe is for 3 years, this is wonderful. It's
yes.
This is just, oh God.
And I will add too that last year they said that the changes that we all submitted were too disruptive to well-known codes. So we addressed that in the comments on the 1120 and the 1110, that these slight changes wouldn't be disruptive. And in the 4346, we said, you know, the 4346 is not a well-known code, so really we didn't feel it would be disruptive, because quite frankly, people don't know how to use it anyway. So we thought it would actually clear things up. So we just kind of put in here the same type of, again, put a patient with prosthetics so that they knew it could be a patient with ortho, it could be a patient with a, you know, fixed retainer, but that they have inflammation. And at the bottom, we put whether localized or generalized.
Love the politics they have in this picture. Get those ortho guys on this. Okay. Comments, questions, anybody? Are we ready to go to a vote? Okay, this
Yes.
is for the 1110 and 1120. Yes, no, or next year? Terrific, terrific, terrific. All right, this is for the revision Before we go to this vote, can I ask a question? Were you ever able to reach or get any call back from Ann Bisrell on her experience on this committee?
No, I didn't.
No, we didn't.
All right, then we'll go back to that. Okay, so yes, no on the 4346 revision. Okay. Everybody vote that wanted to vote. All right, here we go. This is our last one. And then, so Jamie, have you made it, Jamie?
I have, however, I'm going to be walking through the airport and headed to security here in just a moment. So we're making our way.
So is there anybody else from your group that can talk? You know,
I can go for a while.
I'm
Jill
on.
might be here still. I don't know. Okay.
And
So
Linda
I don't have it.
here.
Yes. Yeah, Linda. And I don't have it right in front of me, so I apologize.
Linda, do you want to handle it then?
I can help. Yes.
Okay. See, first of all, everybody, dental codology is my term, and it is the legal term. It's not a space there. It's dental codology is one word. Also, some of you filled out this part and said dental codology, but didn't have consortium. So our the DCC stands for the Dental Codology Consortium, but dental codology is a single word. That's just editorial. There you go. Okay, so talk about, I know you guys had quite a process that you did, so talk to us about how you got here and where we're at now, Linda. Thank you, Jennifer, for being here. We had to sign off.
Do you want to, oh, I saw a beautiful picture. Jamie, do you want to talk first?
Yes, so we started out with going through trying to decide if we wanted to do one code, multiple codes, and ultimately we decided that we would rather have one code really targeted at the high risk of substance use versus multiple codes. Vaping is really big in everything in the media, and that's kind of where we ended up with that and decided we wanted to cover both the opioid problem as well as the vaping problem, which is completely blown up since we started. And then went on to a few of the members in talking, we decided that it wasn't just, not all use is considered high risk. And so we really wanted to target it to high risk. And so what you've got in front of you, and I apologize, I am not in front of a computer or anything else, but that's where we went on that. We did pull the rationale as well, quoting different calls to action as well as the different recommendations by the FDA, the CDC, and the Surgeon General as part of it. And Linda, what do you have to add to that?
Okay, since I can see the screen, could you go back to the last one? There. Oop, there we go. Counseling for the control and prevention of adverse health effects associated with high-risk substance use. We settled on that as a nomenclature fairly early on, and I just recall from last year when we tried to add vaping. It became clear that it wasn't as clear as it is now anyway, that vaping is a big problem, but so are a lot of other things. Not getting as much attention as vaping right now, but anyway, they said we don't want to disrupt the tobacco counseling codes. Okay, but then does that mean we, like Jamie said, do we really want to have one code for every type of advising? And no, we really don't. So my concern with this one is that vaping is not featured very prominently in this code submission. It's there, it's absolutely there, but it's joined with other things. We still have people where I live, lots of troubles with methamphetamine use, and the oral consequences are severe along with other things. Opioids, there's so many calls to action at the national level to do something, make sure that dental health care providers, as well as everyone else, raises the awareness and is proactively talking to patients about risky use and how to, it's not all about cessation, it's a prescribed drug. It may be improperly prescribed at times. It's certainly improperly used, and that becomes high risk. It's improperly stored, which is a high risk for anybody who kind of rifles through your cupboards and drawers, which we know happens. Diversion becomes a problem, and then just a general overuse of opioids for pain management. It's a very hot topic, and we need to play our part in solving that problem. So anyway,
Linda, can I ask a question?
Yes,
In the section that I almost imagine they're going to consider it going to other preventive services, we have nutritional counseling for control of dental disease, tobacco counseling for the control and prevention of oral disease, and oral hygiene instructions. Did you have the discussion on putting the word oral somewhere in the nomenclature to follow that pattern?
Yeah, well, it is in there. Counseling services may include patient education about adverse oral
behavior. No, that's not. It's in the descriptor. I'm talking about the name. In the name, that's in the name, the nomenclature. Again, discussion. I've said it 15 times already. Nomenclature is where,
I gotcha. I thought it, in my opinion on that, is it made the nomenclature, even though there's precedence for it in the tobacco cessation code, and I think I understand what you're saying. We thought it made it longer, and we're already, I don't know, do you want oral and, see, we've got three versions, oral, behavioral, and systemic effects. We could do that again. Do you think we should? Counseling for the control of oral, behavioral, and systemic health effects associated with high-risk substance use.
What do other people think? It's not about what I think.
I don't hate it.
I'm just throwing it out there because, again, I'm looking at the book and I'm looking at, again, where precedence has been and all that sort of thing. So,
I think continuity is good in this case.
Well, committee people?
Kathy, committee people, what do you guys think?
I'm looking up some stuff here.
Let me read it one more time. Counseling for the control and prevention of adverse oral, behavioral, and systemic effects, or health effects, associated with high-risk substance use. Like I said, I don't hate it. It's a bit wordy,
I think it's a good start. I mean, with all the discussion that went on last year with people wanting something, there's a chance they might want to wordsmith it a little bit. I think it makes it somewhat redundant then, because the very first sentence of the descriptor, it kind of says exactly the same thing with a little bit more. Well, there are other codes that do that same thing, so you're okay.
Oh, yeah, absolutely. And if you have it there, you might want to then take it out of the descriptor. I mean, again, there's just, there's...
I would leave it totally in and let them decide if they want it that detailed or not.
I agree. I would say it's a possibility.
Okay, so what's the process? Do you want, shall we edit it that way right now?
And send it back in. We're going to vote on it, but what do we think about that as a group? I'd like to hear some more discussion. I'll call on you. I see your microphone on, Anne-Marie. Anne-Marie?
Yeah, I'm here.
What do you think? What do you think about adding this part, adverse oral behavior and systemic effects, to the name itself?
I think that would be a beneficial part to it, because then that will really narrow it in and keep us in the forefront. So yeah, I like that.
Okay. Catherine Golan, we haven't heard from you yet. What do you think?
I think I agree with your last caller.
Okay.
I like that. I like what it was said. So, kind of.
Okay. Karen Siebert.
Yeah, I like it. I like the consistency of, and also I really, when you read the descriptor, it is slightly different and does do a deeper dive into what we're trying to say.
Patty? All right, well, quick, Patty. I'm going to go through security and I'll be right back on.
Yeah. Patty, this is Eileen. I think what I'm uncomfortable with is the word counseling. I'm totally cool with patient education, all this other stuff, but when you go into counseling, there are people that are highly trained in counseling. There are people that are licensed in counseling. We're talking about things that are not legal. We're talking about if we miss something. I just think that word counseling is a little bit too strong for what we are licensed. I mean, I know what I have learned and what I know. I can give patient education.
The precedent is that we have a code for nutritional counseling. We have a code, and again, yes, we have education in there, but we also have a code for counseling. So counseling has precedent also in the code.
And because it's specifically talking about the oral effects, I see we're kind of outside our normal lane, aren't we? You know, when we're talking about especially behavioral and systemic effects.
I think, behavioral might be more problematic than the word counseling. Yeah. Because when we talk about behavioral counseling, yeah.
Mm-hmm. That's a good point.
Well,
thank you, Eileen. Thank you, everybody. Anyway.
Hey guys, it's Denise. I have a quick thing. What about if you have trouble with counseling, what about if we just add counseling and educating?
It is there. It's in the descriptor. Oh, I see.
I'm in the nomenclature still.
I gotcha.
Dr. Joy, do you have an opinion? We haven't heard from you tonight, I see. Joy? There she is.
I've just been listening to everyone. I'm fine with what has been discussed. I kind of chimed in late, so I'm sorry about that.
That's okay. No, it's all good. Patty, correct you have something in there. What is the not limited to?
Before the word adverse.
Yeah, we didn't have cocaine in there. We felt like cocaine was receding in significance, and vaping and opioids were rising. And they thought,
so is heroin, though. That's why the opioids are getting less. People are.
Yeah, that's true.
Heroin is cheaper.
Yeah.
What if we use management instead of the word control? Counseling for the management and prevention of adverse oral health effects associated with high-risk substance use. I don't mind the word counseling because we're counseling them on their oral health.
Mm-hmm.
Anybody?
Yeah, are we better off just putting is it what you're saying is we're just putting oral in there only and leaving the behavioral and systemic in the descriptor?
Sorry, I was in the nomenclature.
I think.
Yeah, that's what I'm saying. Just
Adding
add the
oral
word
and
oral
behavior.
rather than all of those, behavioral and systemic. Do we want to just say?
Yeah, somebody had mentioned to include oral in the nomenclature, and I think that we should.
I think, boy, but if you just said adverse health effects associated with high-risk substance use in the nomenclature, then in the descriptor, it expands a little bit so you understand what are those adverse health effects. I don't know, man, all of a sudden, and this is what's going to happen at the CMC. What we're doing is what they're going to do.
Well, they did
And
that. Linda, you had an unusual experience. That is not what they usually do. When they try to do it, what happens is what did happen, which they said we shouldn't be doing that. Basically, the CMC is a little bit like you hear about in a court of law. It's already decided almost before you get there. There's a little wiggle room, and what happened is because we had it in our tobacco thing last time, they tried to do something on the fly, and they don't like doing it on the fly. They like having it done. So that was a little bit unusual what you saw last year, but it ended up doing what happened. It gets tabled then. So
Can I put this is Eileen again? With devil's advocate, if we're counseling and if we're educating and we're talking to a patient, and then somebody says, "Okay, I have a problem. I need help," then what do we do?
Make a referral.
But we had notes in there too for the referral of service.
There's nothing. This is Jill. There's nothing in that first one that says any particular person. It doesn't say dentist. It doesn't say dental hygienist. It just says it says what it's supposed to mean, and I don't see anything wrong with the word counseling. It's not we're not directing it toward any particular.
Okay, but now I'm talking now I'm talking back about behavior. And what if somebody does say to you, you have counseled them, okay, and now they're saying, yes, I have a problem. What do I do?
Well,
and you refer.
If I can quote from CDT 2020, because I just got it last week, on one of the scenarios where it's talking about tobacco counseling, it's a Q&A scenario on page 68, says they were asking what code, and it was a tobacco counseling for the control. And what you do is other procedures and referral may be necessary if changes to the tissue are noted. So the idea is that, yes, we're getting the counseling going, but definitely referral. I mean, I would need to refer on any of the counseling codes, nutritional, tobacco, or this, because my wheelhouse only goes so far, but I'm going to have a referral basis. So whether you put something in the descriptor about referral, but I think you can do that in the, that might, I think it's assumed we're licensed healthcare professionals. We're going to refer.
Can I interject just for a second? You made an interesting point, which is we are not doctors, we're not counselors, we're hygienists. So I think it's really important to put oral health effects associated.
I agree.
In the nomenclature because of that, because of exactly what whoever it was that asked that question about referring them out, because we are only limited so much.
Sure.
And again, that's the precedent that's in that code.
I have a thought based on the with the CDT with what they did with tobacco use. So why couldn't we just kind of mirror the tobacco counseling one and say high risk substance use counseling for the control and prevention of oral disease? Could we do that?
That one of the things that the code committee was extremely clear on is they don't want the tobacco counseling code messed with in any way.
Anyway.
Right, so leave that code be, but then add a new code saying high-risk substance use counseling for the control and prevention of oral disease. So those are two separate codes.
Yeah. So really, basically, what you're advocating for is just add the word oral.
Okay, that for me, that takes. It takes it.
Go ahead, Linda.
Okay, it takes away from the opioids part of this code. There are very few, perhaps no, opioid, like oral effects, adverse oral effects with opioid use. It's all about addiction and overuse, and then the risk to the community. If we just stay in our wheelhouse, I know that's our wheelhouse, but we do have, I think we have a responsibility to let's say, to take a hold of this and say, I need to do my part as a dental professional. We have to play an important role, partly because dentists are prescribing opioids. for their patients for pain management. And
But
some
are
of
we
them,
then, I'm sorry, but are we then counseling or are we recognizing? Because we're talking about a couple different things here now.
right?
Because that's a recognition of a problem. We are not qualified to do opioid counseling. I mean, that was one of the things that we came to with our oral cancer. Our
Some
oral
of the
cancer
counseling is
that
preventive.
we wanted to do codes for risk assessment, yet there is not an established risk assessment system. The reason the tobacco there is because there are established systems for tobacco counseling.
Here's what I think about that. If you counsel a patient about appropriate use of opioids and appropriate storage and appropriate disposal, and how to discontinue, if we are the ones who counsel our patients about that, it is counseling. It absolutely is counseling, and it's appropriate for us to do that in order to prevent the cascade of problems that come with overuse. And then just like,
but there is, again, do we have the expertise? Because I'm just looking at, I'm just thinking, this is very, very personal because of what my husband has been through and the medications and the pain management and the pain clinic and the pain da-da-da-da-da-da. To someone on the outside that doesn't know any of that history, that doesn't know any of that, you might see that if that's inappropriate use, even though it's truly is prescribed that way, there's lots of different things. How qualified are we to really go down that road?
That's where the calls to action come in. They're saying that every healthcare provider needs to up their game when it comes to talking to patients about opioid use. Everyone. We all have to accept some measure of responsibility for it. And by having this code and recognizing that, okay, we can't just give patients opioids for the pain management and then say, lots of luck, here you go. The counseling, oh man, it would be unusual, now that I think about it, it would be unusual to apply a code to the patient education that we would give them about opioids.
If I could throw something else in there, this code doesn't mean it's going to be a dental hygienist code.
Right.
There are other people, the dentist in the office, if they're up on that kind of counseling. Right. I had a patient, real quick, he was a bouncer at a strip club right by where my office was. He came in probably in his early 30s, significant cocaine lesions on the inside of his nose. He was very quick to note that, yep, he used cocaine regularly. He needed like about 10 teeth extracted because of caries. And I was able to talk to him about, if you're using all this cocaine and would give you local anesthetic, that could be an issue. I wasn't counseling on anything other than, yes, it was a high-risk substance abuse. I was, telling him what could happen once he goes under anesthetic, local anesthetic. So, I think personally this is a good code. Leave it talk about the little twiggles you're going to do to it. But I mean, I don't think we need to, if we don't feel comfortable doing that counseling, then we don't put it down that we did it. We can talked about something else, but we don't have to use that code as providing it. I think we have to leave it to each of us to know, did I really do true counseling and referral, or, whatever it is that we do. But don't limit it thinking this is only a hygiene code. No, others in the office maybe.
The other thing, too, that we might want to look at is ADA passed a policy in 2018 on opioid prescribing. I'm sure the other organizations, remember who we're talking to. This is something that, yes, it's maybe less about the people on this call, but is there something in our explanation or in our support that we can use the rationale or the policy statements from the various groups that are on the committee that they need this code, so to speak?
So Sharon Perlman, who's on the committee, had a Facebook post celebrating that the Illinois Dental Society or Dental, I don't know if it's association or society, did pass a resolution.
Right.
And about vaping, but it was very specific to vaping, and it was in the midst of, well, maybe around the time that the 7th or 8th death occurred. I just looked at the TV tonight, and they said now we're up to 13. Seems like it's accelerating.
Jeez.
Anyway, so I asked her, can you share with me, was it a policy? Was it a position paper? Was it, what did you actually, or not paper, but a position statement or a policy? What did you pass? And she said, well, she never did get back to me. She said, I want to look at, there were some amendments to it, but it did pass unanimously after the amendments were made, and she hasn't shared it with me. So I would love to see what they did. But again, it's very specific to vaping, I'm sure. It has nothing to do with anything else. So.
See,
Anyway,
I'm looking directly right now at the ADA guidelines related to alcohol, nicotine, or use by children or adolescents, the statement on alcohol and other substances for pregnant and postpartum patients, the statement on alcoholism and other disorders. ADA has policy statements on these things. So we might want to just go back and look at that. But we need to, okay, we're over time. I knew we would be. So we're going to need to decide on where we're at here with this so we can get to closure. Any final anything on this, guys? Okay, we need to vote. Okay, let's talk about now the timeline. We're not done. What's next? Well, again, congratulations to the Oral Cancer Group. Yes, we've got a coalition partner. Just because we haven't gotten them to date doesn't mean we don't have an opportunity to still work with other groups. Remember, we still need to go back. Now, the unfortunate reality, Kathy, explain what you and I talked about on the phone, and then I'll take it from there about where we're at with this stuff.
Right. One of the things with all of these associations is they cannot vote policy without their board meeting. Their officers can't fly and say, yeah, it sounds good, let's support you. With the two organizations I tried to reach out to last time, I was too late to get a board or an organization policy. Most of them don't have board meetings over the summer, and both of them met in the beginning of September to determine what they were going to do till the end of the year. So doesn't mean that we can't go out and research, but for future reference, we need to consider getting to these people like before June to at least partner and tell them what we're thinking of. I would definitely reach out to those partners that you think would fit and be supportive, because maybe they do have policy we don't know about. So definitely understand that they move about as slow as ADHA. They have their annual meeting and et cetera. So.
And I'm gonna say that June is way too late. It's too late.
Probably.
Because this is where strategy comes in. We need to start thinking much farther ahead than we ever really have. A lot of people have done in the past. We've got to think of multi-year strategies, because if we need to, once we have these, okay, let's start thinking about what we're going to do next immediately, because the time to think that through, and then even the people that are at the meeting and they're there, it's like, by the way, we also talked about this at our group. What do you think of doing something like that together next year? We've got to think this strategy through much farther ahead than we are. We can't wait to be done and then get them on, because, well, I guess one of the successes that we can say, and Susan, I'm going to go back to you. with Brian and with the Dr. Nemechek, we worked with them. Not, here's what we did, do you want to sign on with us? They had their opinion. And Susan, you there?
Yes.
They were active contributors to the code. Even with that, because of what changes and tweaks, we had to still bring it back to Brian Hill before he would, before we could officially put Oral Cancer Foundation, and now Dr. Nemechek has to take it back to his group. This is the back and forth, and this all takes time. I get it. You guys are amazing volunteers that have done so very much. But if we really want to be successful, we've got to even start thinking farther ahead. And the doors are not closed at all. So don't stop trying. For me, I had a light bulb moment the other day, and those of you on the call here that are from Illinois, I'm like, duh. We were looking at the guideline, the 2017 guidelines for oral cancer that as part of the evidence-based portal, and I'm looking, and the lead researcher on that his name is Mark Lincoln. Now, I know he's in Chicago because Allison Stahl and I went and met with him. So I called up Allison and was like, hey, you still got personal information? So she sent me his personal information. I'm going to reach out to him and tell him what we're doing and say, is it at all possible for you to be there at that meeting? Because he's right there in downtown Chicago. And he's the ADA lead researcher on the evidence base. That's putting those things together. In addition, it's looking at and thinking about, and Siobhan, I know you were very proactive, as well as Michelle Race, on what ADHA is doing. Are there things we've already talked about tonight that we don't have policy for ADHA? We're going to bring these codes to our submissions, that's part of our timeline too, to ADHA, and say, are there any here that we can add the ADHA name to? The only way the ADHA name can get added is if we have it in policy already. So that's how this stuff works. This is how it starts coming together. Now, here is the timeline that we have to follow. Based on our discussion tonight, we need the final submissions by the 5th of October to Kathy. Now, Kathy's just going to review it. Kathy is not going to rewrite any of this. She's going to just make sure you have all your T's crossed, all your I's dotted, and all the boxes are going to be filled in the way they are. If it's not minor, she's going to send it back to your group to get done, and she'll give you a timeline, because we just have to do it this way. We really do. We are scheduled again to meet 1 month from tonight, which is the 27th of October. Why? Because I really hope to hear that you've made some progress on coalitions and contacts and thinking about what the future is going to be and how we're going to forge the future, because that's what we're doing. We're forging the future. We're not waiting for somebody else. I can't even tell you how much I appreciate. Kathy and I talked earlier, and this group has been amazing. Amazing, amazing, amazing. So thank you from the bottom of my heart. You know how to get a hold of me. I think everybody knows how to get a hold of Kathy. Please, we're going to be successful. I feel really good about it. And thank you all for your time and your attention tonight. Good night, everybody.
Good night.
Good night.
Good night. Thank you, Patty.
Thank you, Patty.
Thank you.
Good night.
Good night, everybody. Thank you.
Good night. Thank you.